Welcome to Washington Hospital Today, the program dedicated to sharing timely information about the community hospital that's been taking care of Washington Township Healthcare District residents since it opened in 1958. Washington Hospital Today is provided for the sole purpose of informing residents about healthcare topics and issues that have been covered during community forums, free health and wellness classes, or as part of educational sessions held during the district's open board meetings. This program is one more way that Washington Hospital helps empower you, the residents of the district, by providing information needed to make informed decisions about your health.
Today's presenter is Dr. David Lee. Dr. Lee is a hematologist oncologist and is co-medical director of the UCSF Washington Cancer Center.
Thank you, Lucy, and thank you everybody who came out tonight for this talk. When I was approached by Lucy a while back regarding talking to the community, I thought this would be a great opportunity because these are questions that come up every day in my clinic. Just this afternoon, I had a new patient to me, a woman who didn't actually have breast cancer, but had a high-risk type of pathologic diagnosis we call atypical ductal hyperplasia. And I was going over a medication list, and I'm like, why are you taking this, a vitamin B complex? Why are you taking fish oil? Why are you taking aspirin? Why are you taking high-dose vitamin C? And the simple answer was, I just want to be healthy. And I want to do everything I can to try to make sure I don't get breast cancer. I want to be as proactive as possible. Earlier this morning, I had a discussion and a follow-up with one of my patients with ductal carcinoma in situ, which is a precancerous lesion for breast cancer, and she had had a mastectomy. And if you get a mastectomy, the cure rates are 98%. That's really high. And I wanted to try to convince her, live your life, don't sit there and try to latch on to alkalinized water or other types of things that she was hoping would provide her that extra 1 to 2% to bring her to 100%. And so I hear from patients all this time this need to try to do more, and a lot of questions and about things that are, some cases, really proven to be beneficial in preventing a recurrence of cancer, have been proven to improve survival, though there are a lot of myths. I brought up here actually a typical patient. I just put Miss X, a 46-year-old woman that I met a number of years ago who presented with inflammatory breast cancer. Very aggressive. It was growing essentially day by day, and you can see it on her skin. She was treated with chemotherapy, then she had surgery. After surgery, she had radiation therapy. And an excellent prognostic indicator was the fact that when she had her surgery, there was no more cancer there. So she had what we call a complete pathologic response to the chemotherapy. Despite her excellent prognosis, she was scared. And a few months after her radiation therapy completed, she came in to see me for a follow-up visit, and she was just in tears. And she was coming into her office, my office, with 2 books. And she said, how come this book is telling me one thing, this other book is telling me the exact opposite thing? And the question is, what do I believe? Who do I believe? And when I sat down and I looked at the books at the end of the day, kind of was reading through the passages, looking at the references, I realized the problem was that the authors were giving advice based off of opinions, not based off of facts. This is pretty common. Patients have good intentions. They want to transform their lives and do everything they can to maximize their chance of cure. She took very proactive steps. She started juicing, taking all kinds of different nutritional supplements. She was a vegetarian for a while. Actually, I think she may have been vegan for a while. She cut out all the refined sugars that she could. She took to meditation, took to reading as much as she could, even changed her job to try to have a lower stress environment, and all in the hopes that it would help prevent the cancer from returning. So I get this question all the time, what can I do to prevent my cancer from returning? And I think I'm here tonight to help to explain to you what are myths and what are realities. And unfortunately, there's no definitive resource. There's also no filters in terms of what people can say and what people can write. And you'll get all kinds of advice from friends, family, neighbors, coworkers. Often they're grounded on opinion, not actually on fact. And so the main focus for tonight's discussion will really be about lifestyle changes that you can do that can be effective, or maybe things that you can avoid doing. We'll talk a little bit at the end about some new advances in cancer therapies, though I didn't want to focus too much on that, just because if you think about it, when we have medical conferences in oncology, we often have it very disease specific. So we may have a breast cancer symposium we do every year in December in San Antonio that lasts for about 3 to 5 days. And for other types of cancers, that's the typical duration of these conferences, which goes to how many different treatments we have to discuss. So it's not really the right venue to talk about this. You don't have to really look at all the components here, but this is an illustration of what we call the scientific method. It's often taught in high school or in college in basic science classes. And I think the main crux of this is to say to yourself, be questioning all the time. And if somebody has something to tell you, wonder to yourself, why is that true? Does it make sense? What is the data to support it? And if there's new data that comes out, well, how do I integrate that and evolve my knowledge base? So that's what this diagram is meant to say. And then over the course of the talk tonight, I'll have references to clinical trials, to journal articles, not that there's any kind of quiz, but also to prove the point that, well, this is why I'm saying this, and this is why we think that something may be a myth, something may be reality. So I'm going to ask for some participation. So if people can raise their hands, do people think exercise is beneficial? Great. So the reality is exercise is good for you, including from the cancer perspective. And I like this picture a lot better than this picture, because this picture looks like modern day torture, whereas I look at this and I say, wow, that looks like fun. Maybe a little bit dangerous, but it looks like fun. So there's been lots of different trials done looking at exercise in different types of cancers. So in terms of breast cancer, I brought up just one study. This was published over a decade ago in the Journal of American Medical Association, or JAMA. They looked at 3,000 nurses diagnosed with breast cancer, stage 1, 2, and 3. They followed them for up to about 8 years on average, and they looked at differences in outcomes and what could be influencing the differences in outcomes. And what they saw was moderate exercise reduced recurrences as well as breast cancer-related deaths by 50%. It cut the risk in half, which is quite substantial. So just kind of as a reference point, women who have hormone receptor positive breast cancers are often prescribed medicines that they'll take for 5 to 10 years. We call them hormonal therapies. They're actually anti-hormonal therapies, and they provide a 50% reduction in recurrence. So we're looking at something that can be done that gives a similar type of result, and actually an additive result to all the standard therapies. And when you look at this and say, well, what is moderate activity? What is inactive? How are they defined? In the trial, they said the metabolic equivalent to walking about 2 to 3 miles per hour. So it's saying going out and walking a mile in anywhere between 20 to 30 minutes, which is generally doable for most people. It may be fast for some people with certain types of joint disorders, but for the average person, a 30-pace mile, I think is actually doable. And so that's what was defined as average pace walking for about 3 hours per week. Inactive was defined as less than 1 hour per week of the equivalent type of activity. This was looked at in colon cancer. And this is really more of a review article that was in the Journal of the National Cancer Institute back in 2012, where they looked at all the different trials. They found 5 different studies looking at exercise in colorectal cancer. And they found in all 5 that if patients exercise regularly after the diagnosis of their cancer, it reduces their chances of dying. And in 3, they show that the benefit is also right about 50% if you're doing moderate activity for that magical number of 3 hours per week. In prostate cancer, they showed in men with metastatic prostate cancer, so cancer that's actually left the prostate gland, has gone to bone or to other organs, that if you walked briskly for 3 hours per week, a 50% lower rate of progression compared to those that walked more leisurely and for less than 3 hours per week. In a smaller study with men with prostate cancer, they looked at a good risk category. So men where we can say, you don't have to do surgery right away, you don't have to do radiation right away, we can watch you. And they were randomized in this study to say, do more exercise, eat well, versus just live your normal life. And in the study, they found that if you were in the intervention group, only 5% during follow-up required a standard therapy like surgery or radiation, whereas 27% in the control group actually had to get therapy. And this is a slide that I borrowed from Pete Carroll, who's the chief of urology up at UCSF, where they did a similar type of trial, where they looked at men with low-risk prostate cancer. And they did biopsies of their prostate cancer at diagnosis, and then they did activity, and they did biopsies again. And all these pictures here are what we call gene expression profiles. And what they wanted to do was look at genetically what happens to cancers with exercise. And you can see if you're not doing much exercise versus you are doing much exercise or more than 3 hours a week of exercise, there's a different expression of genes. And then when they looked at the particular genes that are turned on versus turned off, you can see that there are certain bad growth pathways, bad inflammatory pathways that actually get turned down when people exercise. So this is trying to establish the fundamental scientific basis of why we see improved outcomes if people exercise. It's easy to say, it's hard to do. And I'm often told, I want to do it, I have good intentions of doing it. I had a patient tell me today, I was so good at the beginning of the week and beginning of the new year, but by the summertime, I just kind of petered out. And so there's all these barriers, and one barrier is time. People are busy between work, family obligations, and other personal obligations, where they say, I don't think I have the time to exercise. But I just want to say 3 hours per week sounds like a lot, but if you break it down into smaller increments, I think it's actually more doable. So 30 minutes a day, 6 days per week, equals 180 minutes, which is 3 hours. 45 minutes a day, 4 days a week, gets you to the same place. And if you can't find 30 minutes, 45 minutes at one time, break it up. Because I think most people can say, honestly, they can find 15 minutes or 20 minutes in their day to do something. So for patients who tell me, I'm just too busy with work, I get in really early, I leave late, I'll ask them, well, why don't you try to get up a little bit earlier, get to work maybe 15 minutes earlier, try to avoid some traffic. I mean, that might be a benefit of getting up a little bit early. And then before you start your day, just go for a brisk walk. Do it for 15 minutes, it'll recharge you, it'll wake you up. Go work, maybe at lunch or at the end of the day, do another 15 minutes. You'll get it in. Don't wait to come home, change into your clothes, go to a gym, because the magnetic pull of the couch will be way too strong to resist that, overcome it, and get out and actually do exercise consistently. Make it convenient if you are working or you have other obligations to maximize your time. I'm often told by patients, I just stopped exercising because it wasn't working. And I say, what do you mean it's not working? You're here. And they said, well, I'm not losing weight, or I've gained a few pounds rather than losing a few pounds. But that's the wrong goal. So you shouldn't be frustrated by a lack of weight loss because that's not what exercise generally will do. If you work out enough, like if you're training for a marathon, you ride 50 to 100 miles per week on a bike, yes, you will lose weight. But for most people, that's just not realistic. And so realize that exercise will not lead to weight loss. Do not use that as a goal. Use your health. For those who are motivated by cancer, look at it as a way to help treat their cancer. Don't look at this at weight loss. Just as a reference, if you're walking at about a 2.5, 3 miles per hour pace, 1 mile is the equivalent of 100 calories. And there are 3,500 calories in 1 pound. And so you'd have to walk about 30 to 35 miles to burn 1 pound. And that's why the math generally doesn't work out, and why weight loss as a goal of exercise is often very difficult for people. I'm often told, oh, exercise is boring, because that picture I had of that gym with the treadmills and the elliptical machines, that's what people think about when they think about exercise. And the mental image I want to give patients when they come into the office and we talk about this is to remind them, if they're parents, if they have kids or if they have grandkids, and to think about them when they're young, like 4, 5, 6 years old. You take them to a park or you take them to a playground. They will run around for hours. And at the end of the time, when you want to take them home, they'll get upset and they'll cry and they'll throw a tantrum because they don't want to leave. They were exercising, but they weren't. They were actually having fun. And that's what we lose sometimes when we become adults. We start to think about everything having to lead to a goal. And so with exercise, our goal is, I need to get so much time done, I need to lose so much weight, and it becomes very task-oriented. And so by its nature, you've set up exercise to be boring, or just to be another chore that you have to check off at the end of the day. But keep that mental image of a young kid running around at a park or on a playground, and try to find something that is fun. I put this picture up here of a team, a crew team out on a lake or a river, because I actually had a patient who one day told me in a follow-up visit that she got a random call from a friend saying, you know what, I saw this flyer for going rowing up at Lake Merritt in Oakland. And I decided I would just go ahead and join her. And she had never rowed a day in her life, and she just found it to be so peaceful and so much fun, because you're just out on the water. And then while it's repetitious, just rowing back and forth, but to her, that was her highlight of the week, when she can get back out on the water. I have patients, even in their 80s and 90s, that tell me how they go line dancing every week. And that to them is what their highlight of the week and what they look forward to. And that's exercise, but we don't think of dancing as exercise sometimes. So think outside of the box, be creative, don't limit yourself to just going into a gym. If you like to go to the gym, great, do it, but you don't have to do that. For patients who have baseline arthritis, degenerative joint diseases, you have to also be creative. You know, I often tell patients if they can get into a pool, they have access to a pool, do that. Whether it be swimming or even walking or taking a class, that can really help you actually with your joint pains. Tai Chi, I've learned from many of my patients, can also be really beneficial. You can still walk, but don't try to get out there for 20, 30, 40 minutes at a time. Do very short intervals, like 10 minutes at a time, stop, rest your joints. Later in the day, do the same thing. Diet. I get asked questions about diet all the time, and I have a picture here of superfoods. What do people think? Raise your hands if you think that this is a reality in terms of making a difference. So I think the majority of people raise their hands. And unfortunately, I have to say, myth. There have been a lot of interventional trials done in patients of different types of cancers, studying different types of diets. Low sugar, low glycemic diets, low fat diets, high fruit and vegetable, not quite truly vegetarian or vegan, but really leaning in that direction. And unfortunately, no trial has actually demonstrated that any particular diet has resulted in improved outcomes when we're talking about cancer-specific outcomes, like recurrence or cancer-specific deaths. There was one trial done in breast cancer with low-fat diet that looked really encouraging, and it was the first trial to show a benefit, but with long-term follow-up, actually the survival benefit went away. And so we cannot say that there's really any proven diet that will work. But there clearly are studies that have shown that healthy diet is important for you, and clearly there is benefit in preventing a cancer from developing in the first place. Organic foods sound good, but there still is no scientific proof that they are any healthier for people. There's no scientific proof that organic foods lead to healthier outcomes. Though there is some proof that shows it might be safer. This is actually a meta-analysis where they looked at different studies looking at health outcomes in terms of people who are treated with more conventional foods versus organic foods. And basically the conclusion was, in terms of health outcomes, there's no difference. However, in people who eat organic foods, and when looking at organic foods, there does seem to be less pesticides as well as less antibiotic-resistant bacteria on the foods. So that's why I put here safer, but not necessarily healthier for people. I generally advocate to patients have a common sense diet for cancer. It's okay to eat everything. I often get questions about dairy products, about carbohydrates, about meats. Everything is okay as long as you eat in moderation and as long as we're talking about a balanced diet. I think it makes intrinsic sense to try to have a diet rich in vegetables and fruit. I was once told by a world-famous doctor who speaks about and researches about nutrition, he's been doing this for decades, who advocates that you should have as colorful a plate of food as possible, as long as that the coloring is natural and not artificial. Because most color in food comes from vegetables and from what we call phytochemicals that we can see in there, the different antioxidants that are there. There's all kinds of other slogans I've heard, which is shop the perimeter of the grocery store, because the perimeter of the grocery stores are fresh foods that actually need to be in refrigerators, and they're foods that actually have to be prepared versus foods that are inside that are either on a shelf or in a refrigerator, or in a freezer. The other slogan I like is, if your grandmother doesn't understand the ingredients, then don't buy it. Okay, that means there's a lot of chemicals, lots of preservatives there. How about aspirin? Do people think aspirin is beneficial or not? Myth or reality? Reality? So a lot less people here think that aspirin is beneficial, but it is beneficial, at least in colorectal cancer. Here are a couple of studies, and this large one, 23,000 patients with colorectal cancer, followed for at least 3 years, and they showed that there's 50% less likely to die from colon cancer compared to those who do not take aspirin. There have been studies that have shown mortality benefits actually approaching closer to 30%. This is a relatively short-term follow-up. The lower article is really referring to a particular subtype of colorectal cancer where you see a benefit approaching 40% less chance of dying from colon cancer. There have also been studies that have shown that if you take aspirin regularly, you can actually even prevent a colon cancer from developing. And last spring, the USPSTF, or the US Preventive Services Task Force, actually for the first time made a recommendation that some patients should consider taking aspirin to try to prevent a colon cancer from developing, or for the more traditional recommendation, to try to prevent a bad cardiovascular outcome like a stroke or a heart attack. And generally, the recommended group are people in their 50s to about 70 who otherwise don't have bleeding risks, because that's one of the potential side effects of aspirin. is that it is a type of blood thinner and can upset the stomach, cause stomach ulcers, and cause bleeding. So if there's no history of any kind of bleeding disorder, you're not on any other kinds of blood thinners, you haven't had ulcer disease in the past, then it's something reasonable to consider, and a baby aspirin is all that you would need, taking it daily. And that recommendation is based off the fact that there was a study done here with almost 90,000 participants. In one study, the Nurses' Health Study, 48,000 in the Health Professional Follow-Up Study, that showed close to 20% reduction in developing a colorectal cancer if you took aspirin consistently for at least 6 years. Unfortunately, other types of cancers, like breast cancer, lung cancer, prostate cancer, those have been looked at as well. Aspirin doesn't seem to help there. So it's very specific to colon cancer and rectal cancer. Nutritional and herbal supplements. Raise your hand if you think it's helpful. A few. So unfortunately, this is also a myth. So no high-quality human trials have demonstrated any cancer-related benefits with vitamin supplements, with various herbal supplements, or other type of nutritional supplements. I have patients coming to me asking about all kinds of different supplements like CoQ10, grapeseed extract, resveratrol, turmeric, and oftentimes I'll actually point them to Memorial Sloan Kettering Cancer Center's website. Memorial Sloan Kettering Cancer Center is a world-famous cancer center in New York City, and they have this amazing website, and I think it's in your slides there, where they have this huge compendium of different types of herbs, or what people might consider to be alternative therapies. And they give you, what do people think it's good for, and what are people taking it for? What is the evidence to support that? What are potential harms that can come of these treatments? Different types of herb interactions or herb food interactions, as well as herb drug interactions, because herbs are medicines. I think we have to keep that in mind. There are many chemotherapy drugs that are actually based off of plants, like vincristine, adriamycin. These are actually derived from plants. Aspirin came from the bark of a tree. So when we think about an herbal therapy, we should think of them as a medicine and a medical therapy. So it's important to then think about, okay, what are the potential goods as well as the potential harms or side effects that can happen? How might it interact with some of the medicines that I'm taking? And I put here, be particularly careful if you are receiving chemotherapy. So I've had patients say, how about turmeric? I've read that turmeric can be beneficial in preventing bad side effects related to chemo treatments. And that's probably true because there have been studies looking at turmeric and how it affects people's metabolism of certain types of chemotherapy drugs, where it actually accelerates your metabolism of the drugs, which effectively lowers the dose of chemotherapy that's in your blood. And we can accomplish the same thing just by lowering your dose of chemo that we prescribe for you. And so on the latter way, when we just lower the dose, it's in a controlled fashion. If we're doing it in the respect of affecting a person's metabolism of a drug, then it becomes very unpredictable. And so that's why I say be careful if you're getting chemotherapy. Make sure you talk to your oncologist. You can even look up the Memorial Sloan Kettering website yourself and see if there are any potential harms. And a lot of the purported benefits of these types of therapies are mostly in what we would call cell line studies. And cell lines are taking cancer cells, growing them almost like in a petri dish with an artificial culture medium, growing them up, and then you basically expose it to different agents. And if it's successful in killing off a cancer, then it's reported. But usually that's the lowest bar that we have to say in terms of evaluating a therapy. If you can't kill a cancer cell within a petri dish, then that treatment's going to go nowhere. But if you could do that, then we take that to animal studies. If that's effective, then we take that to human studies in phase 1, phase 2, and phase 3 trials. And so that's why I wanted to make sure I put here no high quality human trials have ever shown any benefits. And if you read through all of these different studies and say, well, why is it that this person has said that it's useful in treating this type of cancer, it's usually in a cancer cell line, not actually in people. Vitamin D, I just went directly and wrote up here, it's a myth. I'm not really sure why so many primary care doctors are checking vitamin D levels these days. And there's actually a few years ago a very well-written article in New York Times asking that same question. And there were a lot of experts in endocrinology and hormones and bones, experts in nutrition and vitamin D, who also shake their head and say, we don't know why doctors are checking it so often. And there are many people who are being misdiagnosed with vitamin D deficiency because for some reason the labs will say you have to be over 30 as a threshold on your blood testing to say you're not deficient. But actually, as long as you're over 20, physiologically, you have sufficient amount of vitamin D. And there have been a lot of studies that have shown a correlation between low vitamin D levels and bad health outcomes, like dementia, cancer, strokes, and heart attacks. Basically, anything you can think of that's bad, low vitamin D level has been associated with it. But this is a correlation. There's no causation that has actually been demonstrated. There have actually been some intervention trials that have been done where people have actually been given vitamin D as supplements, and the question was asked, does this seem to actually prevent a cancer from developing or prevent a recurrence? And so far, the trials have not shown any benefit. The most recent one was published about a year or two ago, looking at vitamin D in patients who had colorectal cancer, giving them supplements after they've been treated for their cancer, and asking with follow-up colonoscopies, can we reduce the rate of what are called tubular adenomas or precancerous polyps? And the studies have not shown any difference in the rates of developing precancerous polyps with vitamin D supplementation. And we think of that as the first step in developing a colon cancer. So if we can't prevent that, probably doesn't make a difference in terms of the actual cancer itself. And for other types of cancers where it's been studied in, so far no benefit has been seen. I didn't put a slide on alkalinization, but I had two patients ask me this today. And so I guess there's a myth out there that says cancers do not like alkaline fluids or alkaline conditions. They prefer acidic conditions. And my response to that is, first off, cancers can live in any kind of condition, whether it's a high oxygen organ, like our lungs, or in a low oxygen situation, they will adapt. Whether it's acidic or alkaline, cancer cells don't care. They will adapt, and they come up with resistance mechanisms, so alkalinization will not help. On top of that, the body actually has a built-in buffering system to keep your pH at a certain level. It wants to keep your blood at a pH of 7.4, which is naturally slightly alkaline. So kind of the neutral pH is 7, below 7 is acidic, above 7 is alkaline. Your blood must stay at 7.4. Even if it drops or goes up a little bit, like 7.35 or 7.45, if that happens, your body gets extremely sick. And if you drop, say, below 7.3 or you go above 7.5, it is life-threatening. So the body does everything it can to maintain your pH in your blood at 7.4. So purchasing $1,000 equipment to alkalinize water, drinking gallons of alkalinized water per day, your body will actually counteract that because it does not like for the pH balance to be upset. And so there's buffering systems in place, including what the kidneys can do and what your breathing will do to offset how you try to manipulate your acid-base balance inside your body. In summary, in terms of lifestyle, greatest lifestyle change that can improve a cancer survivor's chance of cure is exercise. Our goal is 3 hours per week. Aspirin can also be beneficial in preventing a recurrence of colorectal cancer as well as trying to prevent a colon cancer from the first place. Eat a common sense balanced diet. Don't try to go to an extreme diet. You'll probably end up hurting yourself more than helping yourself. Think of nutritional and herbal supplements as medicines, and be careful. So far, studies have not shown any benefit in taking excessive amounts of supplements. Who knows, in the future we may change based off of new data, but so far there's no benefit. And be careful, because sometimes there can be risk of harm. If you have very specific questions, you can look them up. If it's an herbal supplement on that Memorial Sloan Kettering website, talk to your doctors about this as well. And if they don't know the answer, maybe they can refer you to somebody who will know the answer. I wanted to end with just a few slides on some treatment advances. And these aren't necessarily the most cutting edge in some cases, but just trying to give you an example. So in breast cancer, a few years ago, there was a trial that showed that extending hormonal therapy with tamoxifen for 10 years is better than 5 years. So that's today not new. That's been known for a few years, that can be quite beneficial. About 2 years ago, there was a trial that shows that in postmenopausal women, if you are taking a type of hormonal therapy called aromatase inhibitors, extending to 10 years was also more beneficial than 5 years. However, last year, there were actually a couple of trials that showed conflicting data, and those trials showed no benefit of extended therapies. And so the jury is still out when it comes to how long is the ideal amount of time to treat patients with aromatase inhibitors. And so I usually will tell my patients it's about 5 to 10 years until we know better. I might stop a patient at 5 years if they're developing osteoporosis, like weakened bones. That's a side effect of the medicine, because clearly we're starting to harm them from the treatment. I might stop it if they have a low-risk cancer. If it's like a stage 1 breast cancer, the likelihood of extending to 10 years is pretty small. But if I have a patient who's tolerating the treatment very well, their bones are healthy, they're doing well with it, they maybe had stage 2 or stage 3 breast cancer, I might say, well, we don't know for sure that 10 years is better, but why don't we go beyond 5 years and let's just take it year by year, because there'll be more and more data that comes out that will better define it. And if it turns out 5 years was enough, we'll just stop it at that point. If 10 years is better, then that's great, because we're already on that pathway. There was a recent trial that was just published in June and presented at a major oncology conference in May that looked at giving chemotherapy and saying in women who get chemotherapy before surgery, like in the example I gave in my patient X, if you don't have a complete pathologic response, which means if you got chemotherapy before surgery, you do an operation, and there's still residual cancer there, that giving extra chemotherapy with a very well-tolerated chemotherapy pill for 6 months can improve survival. And so this is the first time where we've actually seen this kind of benefit, where additional treatment beyond the chemotherapy that people had before an operation can improve outcomes. So that's why I wanted to include this here. In prostate cancer, we have a better understanding of men who don't need treatment, men who can just be observed. So better categorizing the good risk patients that will die with their prostate cancer, not due to their prostate cancer, and we can leave them alone. For men who do need treatment, particularly metastatic, which means it's spread to other organs, there's new data that shows instead of just giving a hormonal injection, in some men, if you give another hormone pill called abiraterone, that improves survival. If we, in some cases, give chemotherapy with the hormone injection, that can also improve survival. And so we're trying to better stratify patients and say, yes, you need more aggressive therapy, or maybe you don't need any kind of treatment, and trying to make sure we tailor our therapies for people appropriately. To that end, we're learning to subtype prostate cancers. Many people have heard of the BRCA gene in the context of breast cancer and ovarian cancer, but it's been discovered that about 20% of cases of prostate cancer also have a BRCA gene. And there's a pill that's been FDA approved for women with BRCA genes and with ovarian cancer, And this pill has been studied with men with prostate cancer with an abnormal BRCA gene, and it's been found to be effective. So that might be an alternative treatment for those men as well. In lung cancer, there's been a whole slew of advances over the last 5 to 10 years, particularly in the last 3 to 5 years. So what we've learned is lung cancer isn't one type of cancer, it's a huge variety of cancers. And so I put here EGFR mutations, ALK rearrangements. These are basically trying to better define a person's type of lung cancer and saying there are more specific treatments that work better than standard chemotherapy. And there's new advances in terms of the types of medicines for these subtypes. In addition to that, what I put here in the last 2 tabs is a drug called pembrolizumab. You hear this advertised on TV now all the time. Its trade name is Keytruda. And you'll see it in magazines even, advertising Keytruda. And this is what we call immunotherapy. So most people have heard about chemotherapy. Chemotherapies are drugs that will kill off rapidly dividing cells, both healthy cells as well as abnormal cells. Immunotherapy is different. Immunotherapy means how do we harness your immune system to recognize a cancer and to fight off a cancer? And so there are different types of immunotherapy now, and immunotherapies have been FDA approved in bladder cancer, kidney cancer, in certain types of lung cancer, melanoma. It is going to be approved probably any day now in liver cancer, and actually in May, for the very first time, the FDA approved the use of Keytruda for any kind of cancer that has a certain type of molecular change. This is the very first time the FDA has approved a medicine to treat not based off of cancer type, like lung cancer or colon cancer, but based off of a molecular change in that cancer, because that's highly predictive of response to that therapy. And it seems to work regardless of cancer type if you have this particular type of molecular change. And so that's something that many hospitals and pathology departments, oncologists are now adapting in terms of their routine workup of these cancers and checking for it, because it does affect our treatments and it can definitely affect outcomes. And not everybody responds to immunotherapy, but some people who do respond to immunotherapy can have pretty incredible responses, where we have patients with stage 4 lung cancers that a decade ago, even with our best available treatments, would live only for about 6 to 12 months, that are living for 4 to 5 years or more. And so that's pretty remarkable. So pembrolizumab is one such of these drugs. There are other drugs that have now been FDA approved, not just in lung cancer, but other types of cancers. In blood cancers, just in May, there's a new medicine called midostaurin that was approved for AML that have a particular type of mutation called a FLT3 mutation. And AML, or acute myelogenous leukemia, is the most common acute leukemia in adults. And I remember I had this mentor down at UCLA who is the director of the bone marrow transplant service and leukemia service at UCLA, who used to give the same lecture year after year, decade after decade, saying, since the 1970s, we've had no change in therapy for AML. And I saw him on Friday because there was a research symposia up at UCSF that took doctors from all the different UC campuses and UC hospitals. They had this annual conference trying to talk about blood cancers and different research opportunities and ongoing trials. And I ran across him and I said, Gary, how are you doing? I haven't seen you in so many years. And he goes, and I said, I remember all of your lectures still. And he goes, you know, the last time I gave my AML lecture was in April at Cedars-Sinai. But in May, when the FDA approved midostaurin, I have to change it for the first time. And he said, I would gladly do that because the outcomes are so much better in this subtype of patients with AML with the addition of this treatment. We have improved combination regimens for multiple myeloma, and immunotherapy we talked about on the last slide for different types of solid cancers. We're actually finding great results with immunotherapy, a different type of immunotherapy called CAR T cells for different types of blood leukemias. So it's already been approved for relapsed childhood ALL. Now it's being studied in adults with ALL, adults with AML, as well as adults with multiple myeloma. And some of the preliminary trials for CAR T therapy in aggressive lymphomas and multiple myeloma look amazing, where we have patients that have been already treated with lots of different therapies, may have even had bone marrow and stem cell transplants. Their cancers have returned, and they've been enrolled in these trials and have had amazing responses. And now we're waiting for long-term follow-up to see, well, how long does it work for? But it gives us an avenue of therapy that a year ago or 2 years ago we did not have. And what we're trying to do is just continue to advance slowly but surely, chip away, chip away, chip away, and in many patients, cure them of their cancers, and in some where we do not yet have the ability to cure them, make it a chronic disease. And hopefully then, as we make it a chronic disease, a new advance will come out that makes that cancer now curable. So in conclusion, exercise, eat a common sense diet, think about aspirin, at least in the context of colon cancer, be encouraged because the treatments are rapidly evolving and the pace of advancement is actually accelerating rather than slowing down. Talk to your oncologist. Make sure you let them know about anything that you're doing, whether it be a dietary change, supplement that you might be taking, any kind of questions that you might have for them. Address it to your oncologist. And then last but not least, live. This is a common problem I see with my patients sometimes, where it's very hard to move beyond their diagnosis. And remember, everything that we're doing here is for you to be able to live. So embrace that. And I've had many patients tell me that in retrospect, their cancer diagnosis was one of the most important things, if not the most important things that's happened in their life, because it's allowed them to reassess themselves and remember what is important and what do I value. So keep that in mind and live. Thank you.
Hi. I wondered what the long-term follow-up, once someone has completed post-chemo and taken all their tamoxifen or adjunct therapy, after 5 to 10 years, what is the actual follow-up that you would conduct after that period?
So I think this is in the context of breast cancer, because you said tamoxifen. And the follow-up varies depending on the type of cancer, because there are some patients even 2 or 3 years after completing therapy, we will tell them that they are cured. And they do not need very much oncology follow-up at that point. With breast cancer, it's a little bit different. And with breast cancer, part of the problem is that even if we think a woman is cured of their cancer, we never will tell you you are cured of your cancer. Because even later on in life, 10 years, 15, 20 years out, there is a small chance that the cancer can return. So we generally will have patients still come in for follow-up visits. It varies, and some of that just is oncologist specific, some of it is patient specific. So if there's something particularly concerning about a patient, we may still have them coming in at 3 to 6 month intervals. If they're doing well and they've had no concerning signs or symptoms, we would say annual visits. And on the annual visits, it's mainly talking to you, finding out how you're doing, how you're feeling, and then doing a physical examination. Usually, if you have not had a mastectomy, then we would recommend doing a mammogram annually. The role of doing additional testing like a breast MRI is optional, but controversial. So in a woman who's had a history of breast cancer, who has dense breasts on their mammograms, you would qualify for breast MRIs, though there is no proven survival benefit, but insurance will pay for it. Often patients want it and doctors will certainly order it. There is no support to do routine blood testing or routine scanning. So if I think about 10 years ago, I would have patients come in for follow-up visits. You know, I'd say, oh, it's been 6 months since their last set of blood tests. Let's run a panel of blood tests, including what we call tumor markers. Or it's been a year since your last set of CT scans or bone scans or PET scans. But we've stopped doing that. And we've stopped doing that because studies have shown that none of these routine follow-up testing, whether it be blood tests, x-rays, including PET scans and bone scans, they are not beneficial. And they do not improve survival or outcomes. And they are often misleading. So the recommendation from pretty much every national oncology organization is to not routinely do these tests. We may do it if you have a concerning symptom, but in terms of just doing it on a surveillance schedule, no, that's not what we would recommend.
If you didn't complete 5 years of tamoxifen, then would you recommend more of a routine follow-up in terms of a scan?
No.
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 Okay.
Well, first, Dr. Lee, thank you so much for your talk. It was really, I can't wait to call my mother and say blueberries really don't matter.
Okay.
And she's going to say I told you so, and she takes an aspirin every day. But
Okay.
anyway, I'm interested in tamoxifen as well. And there's a 10 milligram dosage and a 20, and all the data seems to be with the 20. But are there any cases or in the literature that support taking 10 if you don't care for the symptoms, or the side effects, I should say? Is there any support for 10 instead of 20?
No. So the 10 milligram dosing is available as an option, usually due to intolerance. And I have some patients that want to split up the dose, where they feel like if they take it in the morning and they take one at night to get to the 20 milligrams, that they just feel better on that. Though there is no long-term data to say 10 milligrams is as good as 20 milligrams. We don't know.
Well, can I just have one follow-up question would be, women that are postmenopausal on tamoxifen tend to, some women do that, right?
Yes.
Are they studied separately, or are they in the aggregate data pool when you look at survivor rates?
So when you're looking at tamoxifen-specific trials, they're in the pool. And they'll break it down with premenopausal as well as postmenopausal women. So they're all included.
I'm postmenopausal. I tried taking letrozole, generic Femara, and it just really debilitated me after 5 weeks. And just what you just mentioned, 3 to 4% is still 3 to 4% when you're considered high risk. So I'm back on tamoxifen. Now I know there's other kinds of aromatase inhibitors. Do they all have the same? I have arthritic knees too, so it was just like paralyzing me. So is it worth trying Aristrozole or I forgot the other two, but there's 3 of them total, and I tried the Femara generic.
Yeah.
So I don't know if I've only been on tamoxifen for a year and a few months, so it's not a long time. So I'm just wondering, should I stay the course of tamoxifen, or should I try one of these other 2?
So just for those in the audience, there are 3 different types of aromatase inhibitors. Those are what we talked about, hormonal therapies and hormone receptor positive breast cancer. And you're doing it in what we call the adjuvant setting, which is you've completed your treatments, you're trying to cure the cancer and prevent the cancer from returning. And with aromatase inhibitors, there are 3. They all have the same potential side effects. So potential side effects are hot flashes and aching. And for some women, the aching, just as you were saying, are really severe. And they can happen right away after starting the medicine. You stop the medicine, within 1 to 2 weeks, they go away right away. So we can clearly prove cause and effect from the medication. The other side effect is osteoporosis, which is weakening of the bones. Even though all 3 have the same potential side effects, some women do tolerate one better than the other. So the way I rationalize that is if you think about ibuprofen, which is like Motrin or Advil, versus Aleve, which is naproxen. They're both what we call non-steroidal anti-inflammatories. And they're classified then in the same category of medications. But I have some patients who tell me, I do so much better with Advil than I do Aleve. I hear the exact opposite from other patients. And so that tells me that there's enough of a chemical difference in their structure that even if they work in the same way and they have the same mechanism of action, that some people just do better with one medicine than the other. So is it worth a try if you're concerned and high risk? Sure. I think it's reasonable to try, though I found in my own practice that many times, I'll try a second drug, I won't try a third, because usually I found that, if you try a second drug and they don't tolerate that, there's no point in trying the third because they're just not going to react well to that one as well. And the other two options, there's, so you tried letrozole, which is Femara. There's anastrozole, which is Arimidex. There's exemestane, which is Aromacin. I'd say structurally, Aromacin is a little bit more different to letrozole than anastrozole is. So if I were going to try one, I would try Aromacin, which is also exemestane. Okay? And if it doesn't work, it's okay. That's actually the most common reason why women will, postmenopausal women will be on tamoxifen, is just because of tolerance.
Okay.
Sure.
We have a question over here.
Hi, Dr. Lee. Thanks for the seminar. I also have a question about tamoxifen. What make the conclusion that take tamoxifen 5 years is 10 years so much better than 5 years? Is some kind of statistic for a 10-year tamoxifen? How much more survivability? What's the percentage? Is there such a report?
Yeah, so there was a study done, and it was directly compared, where women on tamoxifen were either treated for 5 years or extended to 10 years. And then they were followed. And the question was, does treating for longer make a difference? And so in the first 10 years, there was essentially no difference. And it makes sense. And it made sense to us because whether you take it for 5 years or 10 years, at least for 5 years, you're getting the exact same drug. So we shouldn't see any difference in that first 5 years. From year 5 to year 10, it didn't surprise most oncologists that there was no difference because we've known for a long time that after you stop tamoxifen, there is an ongoing effect for about 5 years. So that's something we've already known. What we didn't know was at what point does that protection wane, and going for longer, does it actually improve long-term outcomes? And so that's what the study showed, that once you get to year 10 and beyond, there are less recurrences, there's better survival with the 10 years versus 5 years. I don't have the numbers off the top of my head in terms of what the difference was. You can actually just Google tamoxifen 10 years versus 5 years, and it was published in Lancet, and it'll come up, and then it'll come up there for the exact numbers.